Your symptoms have a shape. The numbness wakes you at night and lives in your thumb and first three fingers, or the pain shoots from your low back down one leg in a clean line, or your foot has gone numb and weak on one side. Unlike a diffuse body-wide neuropathy, this damage has a map, and that map is telling you something crucial. Somewhere along its path, a nerve is being physically compressed. It is being pinched, crushed, or choked. Pain is a signal, and the location of that signal is data. When nerve symptoms follow the precise anatomical territory of a single nerve or a single nerve root, the cause is often mechanical, a structural problem that physical forces have created and that physical solutions can often resolve. Today we examine compression neuropathies, carpal tunnel, radiculopathy, and the elegant, underappreciated phenomenon that makes them worse. Let us understand what compression actually does to a nerve. A peripheral nerve is a living cable that needs its own blood supply and room to glide as you move. When it is squeezed by a swollen tendon sheath, a narrowed tunnel of bone and ligament, or a herniated disc, several things happen in sequence. First, the pressure chokes off the tiny blood vessels feeding the nerve, producing ischemia, a starvation of oxygen. This is why a compressed nerve often feels worse at night or in certain positions, and why shaking your hand brings temporary relief. You are briefly restoring blood flow. If the compression persists, the protective myelin insulation at the compressed segment begins to break down, focal demyelination, and the nerve's signals slow and distort. If it continues still longer, the underlying axon itself is damaged, and the muscle it supplies begins to weaken and waste. Nerves are most vulnerable where they pass through tight anatomical tunnels or over rigid structures. Carpal tunnel syndrome is the classic example. The median nerve is compressed as it passes through a narrow tunnel at the wrist, producing numbness and tingling in the thumb, index, and middle fingers. The ulnar nerve is commonly compressed at the elbow, the funny bone, causing symptoms in the ring and little fingers. In the lower body, radiculopathy occurs when a spinal nerve root is compressed at the spine itself by a herniated disc or by the bony narrowing of arthritis and stenosis, sending pain, numbness, and weakness radiating down the arm or leg in the specific pattern of that root, sciatica being the most familiar example. Now the concept that ties this series together. In 1973, Dr. Upton and Dr. McComas published a landmark paper in The Lancet describing what they called the double crush syndrome. Their insight was profound. A nerve compressed at one point becomes more vulnerable to dysfunction at a second point along its course because the impairment of axonal transport at one site weakens the entire length of the nerve. This has enormous implications. It means a person with mild compression at the neck and mild compression at the wrist may develop symptoms that neither site alone would cause. And it means that a nerve already stressed by a metabolic problem, diabetes, nutritional deficiency, a toxin from earlier in this series, is far more easily damaged by mechanical compression. The mechanical and the metabolic are not separate stories. They compound one another. This is why true relief so often requires addressing both the structural pinch and the underlying terrain. While compression is primarily a peripheral problem, it has a serious central counterpart. When the spinal cord itself, not just a nerve root, is compressed in the neck, a condition called cervical myelopathy can develop, producing problems with balance, hand dexterity, and walking. This is a more serious situation that requires prompt evaluation, and it is one reason that new neurological symptoms should always be properly assessed rather than dismissed. The hallmark of compression neuropathy in the periphery is its pattern. Rather than the symmetric stocking glove distribution of metabolic neuropathy, compression produces focal, asymmetric symptoms that map precisely onto one nerve or one nerve root. The numbness respects anatomical boundaries. The weakness affects specific muscles. That precise mappable pattern is the single most important clue that physical compression, rather than a systemic process, is the driver. Here is the contrarian balance. On one extreme, some practitioners rush every compressed nerve towards surgery, operating when conservative care and addressing the underlying terrain might have resolved it. On the other extreme, Some in the conservative care world insist no nerve ever needs surgical release, which can leave a patient with a severely compressed nerve to progress to permanent muscle wasting that surgery could have prevented. Neither dogma serves you. The truth is that timing and selection are everything. Many compressions respond beautifully to non-surgical care, while some genuinely require decompression, and recognizing which is the art of treating this condition well. The evaluation of compression is precise. A careful physical examination maps the affected nerve. Nerve conduction studies and electromyography can localize exactly where conduction is blocked and gauge severity. Imaging, an MRI of the spine for suspected radiculopathy or ultrasound of a peripheral nerve, visualizes the structural cause. And critically, this is where addressing the rest of this series pays off. Identifying and correcting any metabolic vulnerability makes the nerve more resilient and improves the odds that conservative treatment succeeds. At Regenerve, our approach to compression is staged and precise. For appropriate cases, we offer endoscopic nerve decompression, a minimally invasive procedure to physically relieve the pressure on a trapped nerve, reducing pain and restoring function with far less disruption than traditional open surgery. We pair this, or use as an alternative for milder cases, with peripheral nerve stimulation to control pain, infrared light therapy to reduce local inflammation and support healing, and physical therapy and rehabilitation to correct the postural and mechanical patterns that created the compression in the first place. Where balance is affected, we add balance and gait training. And because of the double crush principle, we simultaneously optimize your metabolic terrain through nutritional counseling and infusion support, so the decompressed nerve heals in an environment built for recovery. When your nerve pain has a map, follow it, because a nerve that is being physically choked can often be set free, and a nerve set free can heal. Relieve the pressure, rebuild the terrain, and restore the function you've lost. If this matched the shape of your symptoms, share it with someone whose pain follows a line. Visit regenerve.com or text 31488 I am Dr. Padda, and I will see you in our next deep dive.